Hello, everyone. Good evening. Welcome to Accountability for Cancer Care through Undoing Racism and Equity, the roles of communities, clinicians, and academics in a quality improvement intervention. I am Sai Sagireddy. I'm an incoming sophomore at Baylor University, and I'm a current Shepherd intern at the Children's Habilitation Center in Chicago. If you're new to Shepherd, I am pleased to welcome you tonight to our event, which is the third of four keynote events we will host throughout the summer. By way of context, SHEP is an inter-institutional collaboration among 24 colleges and universities across the country aimed at supporting undergraduate education about poverty through curriculum, community-based experiences, and a shared summer internship. It is week one of that internship, which includes 157 interns from 23 colleges and universities who are working with over 100 agencies in cities across the country in a variety of fields. Every summer, our academic program frames this experience by focusing on a theme that intersects with our three student learning outcomes: knowledge, engagement, and responsibility. 2021 has us doing to examine the ways in which race and poverty intersect, challenging us to explore the complexity of individual experiences that develop out of the systematic injustices that obstruct access, personal security, and thriving. By doing so, Shep is highlighting the work of innovators in the field who have a lot to teach us about solutions-focused approaches within the fields of social justice. Tonight's event will be recorded and available for later viewing on Shep's YouTube channel. Please feel free to utilize the Q&A button at the bottom of your screen to submit questions for our panelists at any time during the event. Our moderator tonight is Dr. Stephanie Breaker, Associate Professor of Public Health Studies at Elon University. She is a scholar activist, and her work uses racial equity and anti-racism lens combined with community-based participatory research approaches. During the discussion portion of the evening, Dr. Baker will be joining our panelists to answer your questions. Now I'll be handing it over to Dr. Baker.
Thank you for that introduction, Sai, and good evening to all of you who are part of the Shepherd Internship Program and all of our guests who joined us here tonight as well. So I'm going to start sharing my screen and get us started in this conversation about what it means, to do the work of creating institutional change. And we're going to start off with sharing just a short allegory. This allegory is called, the groundwater approach, and it was developed by our colleagues at the Racial Equity Institute. I'm an organizer and trainer with REI as well. And I think it's important to note that all of the, the wonderful things that we've been able to accomplish with this intervention that you're going to learn more about is really a consequence of centuries and decades of organizers, activists, educators, just doing the hard work to create an understanding of how racism was developed, how it shows up, and how it structures our society in order to produce inequitable outcomes. So we couldn't do this work if it wasn't for the many other people who are engaged and committed to doing this work every single day. So the Racial Equity Institute developed this allegory to help us understand what we're talking about when we're talking about the structural nature of racism, and they call it the groundwater approach. So I'm going to share that with you briefly, and then I'll turn it over to my colleagues to talk more specifically about the intervention. And so if we were to walk out of our homes one morning and walk by a lake in our neighborhood, and we see this image, we see one fish belly up dead in that lake. Because our minds are meaning-making machines, our brains are going to be asking questions about what happened to that fish, even if we're not conscious about it. So, we're going to be wondering, did the fish get caught, and then get tossed back into the water? Maybe the fish didn't get enough food. Maybe the fish washed up on the shore and ended up back in the water and didn't survive that time out of the water. So lots of different questions that we could ask about what happened to this fish. But if we were to wake up the next day and walk by that same lake, and instead of seeing one fish belly up dead, we see this image, which is a little blurry, but we see lots of fish belly up dead, at that very same lake, that would require a different question. And so I'm going to actually ask you what that question might be. I'm going to ask you to put that in the chat. So if we wake up one morning and we see one fish belly up dead and we ask, what happened to this fish? And then the next day we see all of these fish belly up dead. What should the question be now? So before we said what happened to the fish, What should the question be now? Put that in the chat for me. Yeah, Grace, what's in the water? What's wrong with the lake? Many of you are right now responding only to panelists. So I do want you to change that blue drop down box to panelists and attendees so that everybody can see your answers. But that's exactly it. What's wrong with the water? Right. And so we say at the Racial Equity Institute that that is similar to thinking about individuals and systems when we're talking about our societal problems. If we're looking at all of our societal problems as a problem of individuals or a problem of fish, then all of our solutions will also be, sitting at that fish or individual level. Far fewer of us have been trained and credentialed and licensed to really examine and fix our systems. And these systems could be our healthcare system, our education system, our banking and lending system. There's so many different systems that are producing poor outcomes for the people who are interacting with them. And so this conundrum kind of between the individual and systems approach is something that I noticed in the third year of my doctoral program when I was doing everything except making progress towards finishing school. So I was spending a lot of time volunteering. And one of the volunteer initiatives that I was really involved in was serving meals to people who were hungry. And that is really important. Like, we should be feeding people, we should be clothing people, we should be providing people with shelter to keep them safe. But one of the things that I noticed as I would, get up every day and go serve food was that even as individual people got out of that line, they didn't need support anymore, the line actually never got shorter. It always filled up with other people who had that need. And so I realized that while serving meals is incredibly important, it's actually not attacking the fundamental problem of why people can't afford to eat in the first place. So if we continue to look at our societal problems as problems of fish or individuals and try to solve them that way, then we'll just be trying to fix fish for forever, where our systems continue to produce these inequitable outcomes. Now, when we're talking about structural racism, we have to take it one more layer. We have to ask ourselves, why are the lakes in my neighborhood and the lakes in Dr. Seikert's neighborhoods and the lakes in TC's neighborhoods and the lakes in all of your neighborhoods producing the same types of fish who are having poor outcomes in them? What is going on? What is the common source of that's filling all of these lakes to have the same toxicity? And so that requires us to ask a deeper question, what's that common source? And what we've learned, as we've talked to hydrologists, is that 95%, over 95% of the fresh water on our Earth's surface is in the groundwater. So water and the groundwater are things that we can't see. And that's the majority of water on our Earth's surface. So all of the ocean fronts, all the lake fronts that we get to kind of enjoy and play in and touch and be a part of, those are the things that we can see. And we see racism in our society as a groundwater issue, that it is the essence of our society because of our history and the way that we've structured ourselves. We live in a racially structured society. And when you live in a racially structured society, then you get racially structured outcomes. You get health disparities, you get education disparities, you get disparities in home ownership. You get disparities in every system because they're all being filled up by that toxic groundwater. So we see it show up in our systems and institutions, and we absolutely see the manifestations of it on individual people, on fish. But if we don't get to the business of trying to understand what's happening in our systems and institutions and keeping our mind on the fact that even as we fix our systems and institutions, that groundwater racism will continue to create toxic conditions and environments, then we just won't ever get to that place that so many of us desire, which is a place of more equity and more justice. So I hope that that little bit of a story about how we see this and how we frame our work is helpful to you. If you're interested in learning more, there is a paper that you can access on the Racial Equity Institute's website that describes our groundwater approach. And at this point, I'm going to introduce my colleagues who are going to share more about the ACCURE intervention. And so first, I'm going to introduce them in the opposite direction that they're going to be speaking. So the last person you'll hear come speak is Terrence Muhammad, and all of their biographies are available, on the SHEP website and when you registered for the program. And some of my community partners always tell me, they say, you know, Stephanie, it's nice to know what you do, but we also kind of want to know who you are. You know, so I'm just going to give a little bit of introduction to them about, you know, who I've come to know them as we've engaged in this work together. So Terrence Muhammad, you know, he's an activist, right? He works for the Hip Hop Caucus, and pre-COVID, you know, Terrence was always, or TC, I don't even know why I'm calling you Terrence. TC was always traveling, going from, you know, being on the ground in Flint, Michigan, raising action or drawing attention and advocating for the rights of people who are living in Flint who deserve to have access to clean water. He was in North Dakota, you know, when activists were protesting against the pipeline. And he's currently the co-chair of the Greensboro Health Disparities Collaborative, which is the community academic medical partnership that created this intervention in the first place. So TC keeps us all grounded about how important the work is that we're doing and how it relates and connects with other things outside of healthcare. And so right before TC goes, you'll hear Dr. Matt Manning. So Matt Manning was the champion, the physician champion for the accountability for cancer care through undoing racism and equity intervention. It's really critical when we're working in institutions, we need to have people who are committed to doing the work and people who can connect with other stakeholders who work within those institutions. And that is what you know, Dr. Manning has done, but he's also a personal contact. So when I found out my best friend was diagnosed with breast cancer, he was the first person that I reached out to, because what you'll also learn about us is that we form relationships. That research is really important and it can be fun, but it also can be broken down into really digestible ways so we can kind of center our own areas of expertise and work together and collectively to solving problems. And when you value relationship development, then you're able to connect outside of the research and within it as well. And so who you will hear from first is Dr. Sam Seickert. Dr. Seickert is a grandfather. You know, he has he was a founding member of the Greensboro Health Disparities Collaborative, and he's been in this work for a really long time. And one of the things that I've noticed about Dr. Seickert is he's very committed to building the next generation of academic researchers who are committed to addressing and dealing with these racial health inequities that persist in our society. So I'm gonna control the PowerPoint here, and I'm gonna go ahead and turn it over to Dr. Seickert to get us started.
Hello, everyone. And it's so wonderful to get to talk to this group this evening, to see young people who are committed to working on these social justice issues that sometimes feel intractable, but they're not. And we're going to explain why. And so the main learning objectives tonight are to explain the differences between system change and individual change interventions to eliminate race-specific inequities in health outcomes. And we're going to talk about, yes, we can use informatics or digital data to point out these inequities in real time, but you also need human responsibility and accountability to be able to move the needle when it comes to disparities and achieving equity. And so the main goal is to provide transparency and accountability, and these characteristics and factors are needed to overcome system-based or institutional-based bias. And finally, we'll be talking about community accountability and how important it is to totally break the glass so that there's accountability and transparency to the world and to the specific community groups that are affected by these complex problems. And the community needs to be involved in designing, implementing, evaluating, disseminating, the whole package when it comes to system change and the interventions that work. Next. So the background, when you're thinking about disparities in healthcare, first of all, we're going to be focusing on cancer disparities, So we can say that Black patients in multiple types of cancer have been shown to undergo surgery and other treatments less often than white patients. That includes colon cancer, prostate cancer, breast cancer, lung cancer, any cancer you can think of. It also goes outside of cancer, thinking about disparities in high blood pressure control, disparities in diabetes, disparities in hip replacement, cardiovascular procedures. The list goes on and on. All right. Even when Black patients start chemotherapy, so chemotherapy is prescribed, they finish therapy less often than white patients. And as a result, cancer death rates for Black patients are higher. And there have been very few prospective studies that have identified systematic causes for less than optimal cancer care for African Americans. And we've actually done a couple of those studies that show some of the reasons that that Black patients don't make it down the treatment plan and perspective the same way white patients do. And there are even fewer studies that show effective interventions that eliminate this trend. Next. Well, tonight we're going to focus on the accountability for cancer care through undoing racism and equity. And if you look at this list, I mean, there are a lot of people who participated in this study. The other principal investigator I have to thank is Jeannie Yang. Jeannie and I have been working together now for 20 years on some of these really hard issues. But Jeannie and I are almost nothing compared to this whole community of people who have been working on this. You can see that there are many people in the Partnership Project and the Sisters Network. These are community organizations that have to do with cancer and disparities and activism to teach these lessons of racial equity. And we worked with a couple of health systems, the Cone Health System, and you can see the list of people there. And people tend to want to think, well, this is a Southern thing. Well, it's not. Disparities in the North and in the West and the East are just as prevalent. And so to make sure that people weren't discounting the work, we involved the University of Pittsburgh Medical Center to be our Northern representative in this study. Next slide. And this was a 5-year study. The intervention was multifaceted, and I'll talk about that a little more in a minute. But the outcome of the study was treatment completion in both curable breast cancer and curable lung cancer. And when you think about the problem, especially lung cancer tends to be much more aggressive than breast cancer, why would somebody not want treatment in a disease where 50% are dead in 1 year if they're not treated, and nearly 100% are dead within 4 years? So really, this whole concept of differential treatment doesn't make any sense. And so the study was a pragmatic trial, and we can say that because it was community-based. We enrolled everybody, and these are people who were treated by usual care providers in a usual care setting. So this wasn't an experiment at a quaternary care center. This was real world. And the study tools and personnel can easily be fit into a routine clinical workflow. And before we go on to the next slide, another thing I want to tell you is that on all these past studies, some people say, well, oh yeah, I know the reason that Black people didn't get treated as well. It's because in traditionally in America, incomes are worse and insurance status is worse. Well, every study that's looked at this has controlled for age, comorbid illness, gender, socioeconomic status, and insurance, and race still makes a difference. Next. All right, so what did we do in ACCURE? And it's really important to note that the Greensboro Health Disparities Collaborative, a community-based organization, were full partners in putting this together. And when we discuss data from past studies where we looked at why these disparities were taking place, there were issues like implicit bias. We saw that a physician who wasn't Black tended to recommend risky treatments less aggressively and less frequently to people of color who had 2 or more comorbid illnesses, while white people still had those recommendations made. So there was this sort of fear of being aggressive and taking risk in people who weren't like them. This is what you call an implicit bias. It wasn't intentional racism, but the trend toward decisions was always the same. So we show this data and we discuss it among collaborative members. And what's the collaborative say? That first of all, you need transparency. In healthcare, we have digital data all the time now. Instead of waiting 5 years to look at these data to see that there are disparities, why can't we look at these data in real time? And the second thing is that the collaborative says we need accountability. People have to understand that there are differences in their care, and they have to take responsibility as care providers that these differences are attributable to something we're doing. It's not that the patients are, quote, non-compliant or not doing what they're supposed to do. And finally, communication has to be clear. That in a cancer diagnosis, oftentimes patients go into denial or they don't understand it. So there has to be serial, regular engagement and clear communication to ensure that that the patient knows what's going on and stays in the system of care. So given these principles, this conceptual model shows what we built to essentially as researchers and technicians to do what the community said. So for transparency, we developed a real-time registry system where information from the electronic health record came in every single day. And there was a warning that came up if a patient was scheduled for an appointment and missed it, a warning would come up. But from our past studies, we know that patients were in the system and not getting treatment. And so we built a system where we talked to the community clinicians and we said, well, what's a reasonable time to get all these things done? So we set up milestones in the system. So if a patient was coming into care and these milestones were not reached, a warning system would come up saying, yeah, the patient's keeping their appointments, but they haven't had their diagnostic test yet. They haven't had their biopsy yet. They haven't started surgery yet, or they hadn't started chemotherapy yet. And so who would communicate the warnings and who would engage patients when they didn't come? So the communication people were, first of all, a specially trained navigator who went through the racial equity training that we went through and was also taught through a series of role plays and case studies what specific barriers were for patients of color. And these navigators, if a warning came up saying the patient missed an appointment, these navigators who developed a relationship with the patients would reach out and figure out what the barrier was and engage and re-engage the patient and bring them back into care. We also had a physician champion. So if the milestone came up saying the patient's coming for their appointments, but they're not going down the clinical path to full treatment, the physician champion would engage the clinical team and say, hey, is this really what you meant to happen? And then in terms of accountability, we would talk to the clinical teams on a quarterly basis and tell them, how are your patients doing? And we would break this down by race. Here's how many of your white patients are completing treatment, and here's how many of your Black patients are completing treatment. So people were aware of the disparities existing in real time. And the final part of this was quality improvement. How can we go along the way and take this information and make sure that care is being elevated? Next. And these are just some technical analysis issues, but we compared it to a historical control group before the study. But in case people argue that, well, things would have got better even without the intervention, we also had a control group that was going on in real time. And then we had the intervention group. Next. And the primary outcome was the completion of treatment. And for lung cancer, you could either get surgery or what we call stereotactic radiation, or radiation for cure. And if chemotherapy were started, we measured to see whether it got finished. And for breast cancer, surgery had to be done because everybody with early stage breast cancer should have the tumor removed. If breast conserving surgery was done, then those patients should have started and completed radiation. And then with certain types of tumor based on size and other tumor markers, chemotherapy needed to be started. And so we measured to see whether or not chemotherapy was completed. Next. And you don't need to know all about the statistical analysis given your stage for career, but just know that we completed for we measured and controlled for comorbid illness, median income, insurance status, marital status, gender, age, and all the other things that we talked about before. And then we did a very sophisticated regression analysis to prove what was happening was attributable to what we said it was happening from, particularly the intervention. Next. And here are the results, the bottom line. And at baseline, the difference between treatment completion between white and Black patients was nearly 8% in absolute terms. In the intervention group, there was no statistical difference. And then finally, in the concurrent group, there was a 7-point difference. But what I want you to notice is not only did the disparity in care go away, but care got better for white patients. Next. And again, this is a very complicated slide, but this was the multivariate logistic regression analysis. And the bottom line of this is when we compared the intervention, the Black intervention, to either the white concurrent group or the white retrospective group, which were the groups that got the best care then, what we proved is the Black intervention equalized care to both those white groups. And this analysis also proved that the white intervention was better care than the white concurrent and the white retrospective group. And it also proved that using all those other statistics, all those other variables, that the Black intervention was comparable and equal to the white intervention. So in other words, it wasn't anything else causing it, okay? It was the intervention of transparency, accountability, and communication. Next.
Thanks, Sam. So I want to talk about how the ACCURE system change work fits into our hospital's mission work. During the ACCURE study, I served as the physician champion, and I've more recently become the chief of oncology for Cone Health, which is a community health care system in central North Carolina. We believe that the ACCURE systems change sets an example that not only applies to healthcare, but these types of systems changes could be implemented in education, financial institutions, and far beyond healthcare. So when you think about how this fits into our hospital's mission work, our hospital's mission is to keep our community healthy and to connect healthcare to wellness, not just for a privileged population, but for our entire population. The real-time warning system derived from electronic health records helped us to identify patients who had missed appointments and patients who missed anticipated milestones in care. When you think about the groundwater analogy, when a patient misses an appointment, is it the patient's fault? Are they non-compliant? If many patients in a certain population miss appointments or miss milestones, it's probably not the patient's fault. It's probably not non-compliance. It's probably that the system is at fault and does not provide adequate access or safety nets to guarantee success. Another component of the ACCURE intervention was feedback to clinical teams regarding completion of cancer treatment according to race. We were able to do this in the ACCURE study. The question is, how do you implement this in the long term? And it's important to consider that the data, the electronic medical record data that you have, needs to be accurate. And so it's important that when patients are being registered, that we get an accurate description of race, ethnicity, and language. And health systems are working to improve the data, and using tools like Slicer Dicer in our Epic electronic medical record, we're now able to go back and look at outcomes, look at completion rates. In addition, it's part of the ACCURE study was the health equity education and training, covering topics and concepts such as implicit bias, institutional racism, and privilege. We're continuing to offer these educational elements in person, and we've also created computer-based learning modules. The ACCURE physician champion and nurse navigator were critical to the success of the ACCURE study. Anytime I think you're trying to engage and collaborate with a community, you want to enroll a trusted stakeholder in the community, whether it's a group of physicians or any community. You want to have a trusted stakeholder who has credibility and trust, and that they can also serve as a translator to translate concepts to the language of physicians or the language of healthcare providers. The ACCURE physician champion and nurse navigator were specially trained in particular barriers and beliefs that limit care for African Americans, and they also participated in anti-racism training. At the completion of the ACCURE study, our nurse navigator was promoted to be the chief of all of our nurse navigators in oncology, and now we're training the other navigators in the REI anti-racism workshop. Next slide. In terms of sustainability and dissemination and next steps, I'm not going to tell you this is easy work. There is momentum of a study like this, and there is a reflexive action of the system to revert back to normal. And so in terms of sustainability and dissemination, we have to apply this work. And we, again, kept the ACCURE Navigator and promoted that individual. We've also custom built a real-time registry into our electronic medical record. And so now we're in the process of applying this and implementing it in breast and lung cancer patients. We look to spread this to additional malignancies such as colorectal cancers and other malignancies, and expand beyond oncology to hypertension, diabetes, maternal fetal care, as well as advocate for institutional changes to eliminate the impacts of racism in other ways, including organizing racial equity and cultural humility trainings through computer learning modules, in-person events, and also disseminating the results of the ACCURE study to raise awareness amongst the entire healthcare team. Next slide.
Thank you, Matt and Sam. So, you know, you heard of a lot of information, a lot of data, a lot of information that was given out. It's just very key for the audience that we're looking at. And I am so happy to be in this midst of all these numbers that have tuned into this conversation. So I'm represented, as Dr. Baker has said, I'm the community or the co-chair for this wonderful organization called the Collaborative, and I'm also one of the community representatives. And I hail from Greensboro, North Carolina, and the reason why I represent this beautiful city, because this is the city and home of North Carolina A&T State University. As you can see, I'm wearing that. But the significance of this is that there were 4 freshmen at North Carolina A&T, and I bring that up is because a lot of times we look at magnificent or major change coming from adults or elders, but those young people. So I'm appreciative being in the midst of you as young people that's going to make a difference and make the changes that we need in the areas of health disparities or the change of health, and that would cause us to have better outcomes from everybody. So one of the things about when I brought up North Carolina A&T in 1960, 4 freshmen sat in at the Woolworth counter and started the sit-in movement. And with that sit-in movement, we know what started moving across the country to integrate multiple lunch counters. But also Greensboro is the home of the Simpkins and Cone landmark federal case, as you can see on here, that caused the integration of hospitals nationwide. And this will just happen 3 years later after that significant sit-in movement. Then we're watching the movement of the integration of hospitals. And as we move on, I want to introduce you all to us and who we are, the Greensboro Health Disparities Collaborative. This is a group of wonderful individuals that I would have never have known that 18 years later, I will actually be still here as a part of this beautiful group and this beautiful group of people that's working together, that's in the healthcare field, in academia, and also community. And as you can see, our mission is to establish structures and processes that respond to, empower, and facilitate communities in defining and resolving issues related to disparities in health. And some of the times I'm that voice in this group that translate all of the things that are said, because the reality is that we don't need folks in the community, people in the community don't need somebody to come fly down empower them. The community has power. We need to recognize the power of the community, and the community knows what is wrong with them and what they feel is necessary. And we want to always make sure that there's a collaboration with the community and the community voice, so that the community can be empowered and we can work with our resources to help and facilitate how we all can collectively come together to have a dialogue and resolve the issues of health disparities. And as we have recently seen in the midst of COVID, A lot of the health disparities that the community has already been suffering and already have known have been more so brought to the community light as we look at food deserts and we look at all of the things that was leading to deaths around COVID. So we just make sure that we're engaging the community in all the process that we have. So as we continue, we wanted to talk about our framework. We wanted to talk about who we are and what do we do and what is the significance of what you see on your screen, the anti-racism framework. This is a very powerful framework, and it's a necessary framework because as Dr. Baker showed you in the beginning, a lot of times we look at the fish and we say that poor fish and we try to fix the fish and we want to help the fish, we want to resuscitate the fish or throw the fish back in the water. But it's a different thing when you understand, and you saw the other picture of all the fish just washed up on the lake. And then you got to really start looking at it and say, it's not this individual fish fault. You know, what is going on with this lake? What is going on with this system? And we look at this and we see it as systemic racism, a system of oppression, and unconscious or not, whether you're doing it intentionally or not, it's a system that we have to face. So part of being a part of the collaborative, since we started in 2003, every member of the collaborative had to go through a undoing or anti-racism training, a 2-day training given by the Partnership Project of Greensboro, the community-based organization and nonprofit, or through the Racial Equity Institute. And we wanted to make sure that we had this common analysis. And this is a way that we are learning to how to community organize and fight against community change. And this also provides us with a historical institutional understanding and shared definition of racism. And usually when you're in a room, if you ask everybody what racism is, everybody will have a different analysis or a different definition. But we want to make sure that as we are doing this work, that we have a collective definition to talk about and to share. And we also wanted to make sure that people knew, not because of someone's social economic status alone does not explain racial inequity. And system level inequities cannot explain why are explained by a few bad apples. But even with that, one of the things that this has helped us with is helped us with a conversation. Sometimes it says we don't talk politically correct in our meetings all the time. And what that really means is that we have real conversation. We have real truthful dialogue where we really can share and dig into these issues of racism and systemic problems. And where everybody comes to the table, you take off your medical hat, you take off your academic hat, and you take off whatever hat you're in and come in and have a dialogue. But you bring with those titles and with those hats, the resources of knowledge to help to facilitate this discussion, to help work out this problem. But we all are a collective body of those that have come, postdocs, professors, and like I said, those in the medical profession and myself in the community, to really use this analysis and this framework to really delve into and analyze and work out the understanding of health disparities through an anti-racism framework. And that's why our collaborative is focused on not fixing the fish, but we are focused on fixing the lake. And we will recommend, one of the recommendations for this after this is that you complete the REI, the Racial Equity Institute's phase 1 training. Is another action that you should and want to possibly consider. And so one of the things about this also is that the participants analyze the structure of power and privilege that hinder social equity, and we have to address power. And so that's why we see a lot of movements. We want to speak truth to power. And sometimes that is not an easy process, and it's not an easy thing to do. As we go on, here's the part of this whole process that got me involved. I walked into a meeting over 18 years ago. I really didn't know what I was getting into, but I'm here today as the co-chair. A lot of the things that you heard from Dr. Manning and Sam and about the analysis and the outcome, one of the beautiful things and the unique things about the collaborative is that we are community-based and participatory research, and we work together. It's a collaborative and co-learning, as I already said. And as we work together, we develop a common framework, a common vocabulary, so that all of us can talk in a language that we all understand. You know, if you coming from different countries and different languages or different dialects, sometimes it's hard to understand one another. But when you are coming to the table and everybody is making sure that we're transparent and we're all held accountable to the things that we do, we speak through a lens called a value contract that we all assign, and we value one another's opinion, we value one another's expertise to bring a process where we can help get to the point of health disparities. Also, with this common framework and language, it helps us to deal with structural racism in health, and we decide to take this CPBR approach will enable the partners to be involved step by step. And what that means is that when we started, everybody was involved in the grant writing process to work on at first our ACCURE and then our ACCURE project and the participant recruitment. We all worked in the recruitment, the data collection, the data analysis, the data interpretation, and now we're still in the dissemination of this. But that is just saying that all of us was a part of the process. Not one did one process. We all, so even with me, I had to learn all of the different things in the medical world, all the different things in the academic world, and as well as those in the academic and medical world had to learn the narrative from the community's perspective. But we all learned this process together through our anti-racism training. And with that, both of these guiding sets of principles, the anti-racism and the CPBR, helped us to learn more about the root causes of racial disparities and health outcomes in the healthcare system. These principles are the foundation of our partnership. And I just wanted to share that because this is one of the most important things, because when you start to go out into the healthcare field and go out into work, that those beautiful community relationships that you may start to venture out into the community, you always want to go with a partnership, and a partnership means together and not one above another. Value the partnership of community and their voices, just as those that are in the fields, we value the expertise, but we all are in this together to have a beautiful and well and healthy community.
And so the moral to the story, and I want you to think about this a lot. So ACCURE was a system. We weren't depending on one doctor getting over their implicit bias, or one front desk person getting rid of their implicit bias, or a patient misunderstanding the situation and then disappearing into space, never to come back. We weren't depending on individuals to have to just reappear or make decisions. That's not how the problem was solved. This was a system-based approach, a digital system, a communication system, a data system. And so getting to the moral of the story, work with affected community. You have to work with affected communities to determine the appropriate outcome measures. The measures need to be calculated and presented according to race or whatever other disadvantaged group that you want to help. But of course, you know, racism is an overwhelming theme. You have to apply interventions that include real-time transparency and accountability with excellent communication. And just doing the intervention isn't enough. You have to measure. If you don't achieve your goals, you need to tweak it and then measure again until you get it right. And when you think about this, so data just came out yesterday on COVID, on losing life expectancy in the whole adult population over the last 2 years. And with those 600,000 deaths we've had so far, the life expectancy of whites went down 1 year for Black people went down 3.5 years. For Hispanic, Latinx people went down 3 years. So what you're seeing by that is we failed. We didn't build a system. People of color didn't have as much access to care, didn't have as much treatment, and they were involved in professions where the disease was at a high risk, but we didn't systematically dispense personal protective equipment. You know, there are a few other factors as well, but anyway, let's not fail again, because building a system like this, we can apply to transparency in police-related violence, in banking, in education. Matt kind of said that before, but I want you to really think about this, because you're the young people, the world is in your hands, and you're going to have to fix it. I'm at that upper end right now. I'm running out of time.
Well, I'm not at the upper end. I just turned 50, but I'm at the lower end. I'm gonna keep saying I'm at the lower end. But one of the things that all of us are saying is that we are trying to prepare everybody to be effective organizers for justice. And we here at the Collaborative want to focus on the lake. And as beautiful as this picture looks, and as beautiful as the scenery looks, we know that these lakes and these beautiful sceneries are not always the ones that communities of color see. These are not the ones that usually our people see, that are now being polluted, the air and the water. So we collectively want to concentrate on cleaning up the lake, cleaning up the air. And our ACCURE intervention not only has good outcomes for Blacks and BIPOC people, but it has community good outcomes for whites. So overall, when we are trying to change and work on health disparities, is for the overall community, that everyone has better health outcomes, so that the health disparities not only change for one group, but it changes for the better for everyone.
And this is a three-legged stool. We just talked about the medical system and building something in the medical system. And when you think about it, the vast majority of clinicians came into the profession because they're idealistic. The medical system has digital data, and the medical system has money. So we ought to be able to do this in every instance in healthcare. But we also have to keep in mind that there are things going on in society like food insecurity, not getting a living wage, not having transportation, not having housing. And so we have to work on those things too. And finally, I have to acknowledge that there is a physiology of racism, whereas people who experience racism have physiologic changes, including cortisol dysfunction, that lead to worse health outcomes. So we have to end racism, of course, but it's not going away overnight. So we have to work on ways to attenuate those physiologic effects. I guess that means we're done.
Okay, thank you all so much for to our panelists for that wonderful discussion. Just a quick thing, I am Dan Santo Domingo, a rising junior from Center College in Danville, Kentucky. This summer, I am working remotely with United Planning Organization in Washington, D.C. From Los Angeles, California. And just a quick reminder to the folks on this webinar, if you have any questions, please utilize the Q&A button on your screen to send us your questions. We will get to them as much as time will permit. So to our panelists, I'll start with a question from Myasia Watson regarding implicit biases. Do you think it would be more beneficial to acknowledge these implicit biases that cause health disparities, specifically to the Black community, are an act of racism / anti-Blackness and anti-Black racism, no matter how a person feels?
Yes. I mean, within your question, you answer the question. And I think that is the depths of the groundwater training, the anti-racism training, the 2-day training, is because it takes it out of the personal place and space, and it goes to the systemic. And those are the things. And the reality of implicit bias is not necessarily attributed to one race. We know that how it's detrimental to BIPOC and people of color. But the ideas of implicit bias affects us all. So yeah, we want to make sure that people understand we're looking at systems and we're looking at structures that shape our thinking, shape our minds, shape our images. Just as we listen to music, we see the media and what the media feeds us, and they shape the way we think. So sometimes we think we have the real thought, but we understand that the systems make us see certain things and view certain things from a certain way that has a negative outcome, particularly and dominantly on BIPOC and people and indigenous people. So what like I said, within your question was actually the answer. And we are seeing that with the work, particularly in the healthcare system.
Okay. And I guess a follow-up to that. So historically, there is, this refers to Dr. Seikert's explanation of differential treatments. Historically, there has been this medical paradox that dictates Black Americans are biologically inferior, yet they can endure a certain amount of pain for exploitation. Do you see this? Do you still see any residue of this same logic manifest in modern medicine? And if so, like how does that relate to differential cancer treatments?
Well, yeah, I'm not sure how it relates to differential cancer treatment, except to say that when you don't have real-time transparency, you can make a decision because of your implicit bias or just because you're tired. That's a silly decision. I mean, I'll give you an example. When we first started doing the lung cancer work, I had a surgeon come up to me and say, I'm so glad you're talking to me about this, because I'm realizing more and more that when I make decisions at the end of the day for Black patients, I'm doing a horrible job. But again, that's a great realization on that part, and he might spontaneously catch one or two instances of that. But on the other hand, if I have a system that digitally flags it, then something's going to happen as long as I assign a human being to take responsibility for what happens next.
Anyone else on the panel?
Well, go ahead, Doctor. Go ahead, Matt.
Sorry, I would just punctuate what Dr. Seikert said, that really is the basis of systems change rather than individual change. That I've never seen a bad apple at the grocery store, and it's not because there aren't bad apples, but because the systems that the grocery store uses and the orchard that they get the apples from, and every step of the way is designed to ensure that just doesn't make it all the way through. And I think having the system that checks people and that really just provides that feedback, provides the transparency and accountability is what's needed here, regardless of individual implicit biases.
I just wanted to chime in that I think, for sometimes people are kind of wondering, like, how does this impact me and my family? Like when we go into healthcare, it's like, are my providers going to be treating me in a way? Because the reality is while we have this successful ACCURE intervention, there are very few hospitals who have systems of transparency and accountability built into them. So when it comes to navigating like your patient care today or tomorrow, I think it is important to be aware and cognizant that some providers do hold those beliefs that, in particular, Black people can endure more pain, right? So that might be something that you interact with in the present as we're trying to shift and change our systems and institutions. So I think, the contributions of ACCURE were incredibly important. But I also acknowledge that every hospital system that you're going to navigate is not going to have those measures intact. And so we do have to kind of, in the meantime, be aware of how we might be treated based on, assumptions that folks are making about us, and the power dynamics that are kind of embedded in navigating care when you're a patient versus when you're a provider.
Yeah, that's a great point. And medical schools are doing a much better job of teaching these concepts over the last couple of years. And I mean, I'll be honest with you, when I was in medical school, if a patient didn't go down the care pathway, it was, they're non-compliant. It's not your job anymore. I mean, how stupid is that? But anyway, did I use the word stupid?
Yes,
But,
you did. But Sam, I want to jump in here, because one of the things I really want to highlight within that question, and something that Dr. Baker said, is that most of the medical institutions may not use this process or use ACCURE or recognize this implicit bias, and they still may be practicing this. One of the things that is very difficult to work with, and the ACCURE, the Collaborative is a blessed organization. We're blessed because we stayed together for now 18 years. Some people have become, students have now gone on to be professors, people have had families, but that core group and a lot of added to that group have stayed, and we have grown for 18 years. But let me just give you a look at something. I'm a community person, and just look at the narrative now as we're looking in the condition, and we're looking in the city of, looking in America, we have the George Floyd dynamics, where you see someone killed, right? And you see health disparity outcomes, and they're there. The data show their health disparity. That the data just shows it. So you see somebody get murdered, but then you're waiting. How long do you have to wait for this trial to come up? And then how long do you have to wait for the sentencing? And so we're looking at George Floyd murdered last year. We just saw a verdict come out this year, and we're still waiting on the sentencing, right? And that's just for one person, but that does not deal with the overall systemic issues of police brutality and police accountability. And this is just one issue. So understand that it took us 18 years to do one project called ACCURE, and then to do ACCURE, to now have to battle to disseminate this information, because people may not want to accept the information. But as a community person, you mean I had to do all this 18 years of data and the research to just get it to prove my point, which I knew 18 years ago, but I can't speak on it without having empirical data and research to move this into a discussion that others will look at, and then now systems may actually want to help. So when Dr. Menon said he was a physician champion, that meant that he came on the board because not all physicians even have time to come on board to deal with another project. And then he came on, and now because he came on there early now, and he's now the chief oncologist, he's in a better position to kind of bring this more into this discussion. And I bring that out is because this work is very significant, but we are, as you said, for years and years, that threshold of seeing people of color, that is a mindset, and that is a system that has been perpetuated and still goes. And this work helps to kind of push on that, but we still got to push. So the conversation that we're having here with you all is for you all to come on and pick up this conversation so you can push into these medical spaces that you're about to enter.
Yeah, and another point about that is that, so when the ACCURE trial was first published, and another trial that we published related to it, it got almost no uptake outside of the journal articles. And then when George Floyd was killed, then all of a sudden people were interested, and it's great that people are interested, but if you don't build the system where you measure stuff and improve it, then nothing happens. And you look to the George Floyd situation, he was convicted, but how many police departments are transparent with that confrontational data? It's the exact same problem and needs the exact same real-time system for intervention. But the good news is a lot of medical institutions are contacting us now. So we expect things to get better.
And Chauvin was convicted, just to be clear.
Yeah, that was good, but he's one guy.
Yeah, I just want to be clear, because we always say it was the George Floyd trial, no, the Chauvin trial.
Yeah, thank you.
Yeah, no problem.
That's a perfect segue to Grace Monty's question. They said, do you believe that education medical school is a contributor to systemic racism found amongst hospitals/medical treatment facilities? And if so, what could be a possible what could be a possible redress to this, a cure for schools, question mark?
Yeah, and the answer is yes. And the ACCURE trial is now being taught at UNC. And there's a course called Racial Equity in Medicine. And UNC is getting ready to do the measures that Cone is doing. But anyway, yes. So in the past, I think medical school has contributed to systematic racism in many ways. First of all, we don't admit enough people of color. We use formulas and old wives' tales that are different. For instance, the formula we use to measure kidney failure scored Black patients higher, so Black patients were less likely to get into intense specialist care and get transplants. Okay, so that's a systematic thing. So all those things now are being realized, fingered, identified. In our course in dermatology, they didn't have any pictures of Black skin. And the students in our course brought that to the curriculum committee, and now those pictures are there, to diagnose problems in Black people. And so, yes, medical schools have contributed to this. Things are getting better, but they ain't there yet.
Yeah, I just also want to just jump in and say that, and I appreciate the question, Grace, where you're saying any schools, right? Because it isn't just a medical issue. Of course, we're talking about the healthcare system today, but we all know that collectively we have a horrible education about race and racism in our education system. I mean, most of the time you are going to have to take a specialty type of course in high school, sometimes in college, maybe, but we don't really require anybody to know anything about race or racism, even though all of our systems produce inequitable outcomes due to racism by race. And so the other thing that I think is really important to note is that it was scientists that put forth this racialized idea of genetic determinism, right? That there was something genetically different about people of different racial and ethnic groups, and it was justified by scientists, by physicians. And so, when you have that foundation of a field of study, then it's going to seep into every aspect of that field of study. And we have to kind of take that apart, right? There are medical school books that you can look in where they say, look at the size of the brain of a Black person versus a white person versus Asian person. So you have to kind of unpack what's happening in your system and the ways in which racism kind of seeps into the very culture of medical school, or the very culture of, training people to be educators and teachers and things of that nature. And the other thing I just want to say is, while, we say this is movement work, this is not moment work, right? Because we have to capsize on those opportunities to start shifting and changing things. And we have to be ready. We have to have the analysis ready. We have to have the data ready. We have to have the ideas ready, because many people knew decades ago, right, that there was a lot of problems in medical school training, and people talked about it. People got fired for it, right? So now we're seeing shifts and changes in medical school curriculum, but those same shifts and changes, people 30 years ago were fighting for these things, and they were, penalized for that. So we have to also pay homage to those people who lost their careers, fighting for these things that we're now getting to reap the benefits of in the present moment.
Yeah, and Dr. Baker kind of stole my thunder about what I was getting ready to say, but no, she's definitely right. But that goes back to one of the part that we said everyone needs, and I implore you to research the partnership process project, or REI, the Racial Equity Institute, and take the 2-day training, anti-racism training. Because once you take that, then you will understand very clearly that it's not just in the healthcare system. Any system that touches you, economic system, educational system, religious, all the systems have this bias and has this innate in our country racism, and you have to really understand it. And until you understand that, nothing else will make sense to you. And I say that is because when we're having this discussion, one of the real serious things, and so it's very serious to me, because the reality is that some of us was happy about Juneteenth last Saturday. Yay, you know, national holiday. But here's the thing you got to look at. If you look at it from an anti-racist lens, then you know that we didn't ask for Juneteenth. We asked for anti-lynching. We asked for voter rights. We asked for things that will actually help us. But we got 40 states that are pushing voter suppression. So now there's a push to stop critical race theory in schools, where you can even have a discussion. So now we have a national holiday, Juneteenth, but you can't even talk about it in the school system. So the whole issue of, if you really want to have this conversation, you cannot be void from this national conversation of that we don't want to discuss race. We don't want to bring up race in any particular field or in our discussion in our schools. So you have to push on that and recognize that, like you said, it's not just in the medical system, it's in a whole process of education that we have to change and we got to look at. And having the analysis will help you to start looking at things differently and analyzing it and as you're doing this work.
All right. Thank you so much for everyone. That's all the time we have for Q&A. That was a great discussion. Thank you so much for our panelists, and I'll turn it over back to Sai.
Thank you, Dan. Thank you, panelists, for such a vast array of information. I know I learned a lot about the Racial Equity Institute with the groundwater approach, learning about the ACCURE Navigator, how medical records have changed, and the collaborative efforts of many professionals. Thank you for everyone for coming out tonight. And before I let you guys go, I want to remind you that our next keynote, History, Housing, and Heat, the Impact of Climate Change on Low-Income Communities of Color, is on July 22nd. Thank you, everyone, for coming out.
Thank you.
Thank you.